Hello, my name is Ravi Vij. I'm a professor of medicine at Washington University in the section of Malignancies and stem cell transplantation. I'm here with my colleague Neha, who will introduce herself to take questions. Look forward to a lively discussion.
Hi, I'm Neha Mehta-Shah, also from Washington University in St. Louis, also in heme malignancies, and I specialize in lymphoma and all forms of lymphoma, including T-cell lymphoma. And pleasure to have all of you here, and we look forward to answering your questions.
So I'll start off, Neha. I guess there were a couple of questions that came in through the chat while my session was on. So the first one was regarding ponatinib in CML and whether with a history of venous thromboembolism do you use aspirin prophylaxis. So I think that certainly if you have a history of venous thromboembolism, you may actually have to use full anticoagulation if you're giving ponatinib. I think that if you don't have a history of prior venous thromboembolism, even then there is a heightened risk for venous thromboembolism, and depending on the risk factors, aspirin may be needed. So yes, ponatinib is a drug that is fairly active and is probably the best in terms of efficacy among the TKIs for CML, but we do need to take some few precautions.
I think one of the questions that came through in my discussion was whether there are ongoing phase 2 studies looking at fixed duration BTK inhibitors with obinutuzumab. And so there are, I think, as I mentioned briefly in my talk, there are 2 US intergroup studies that are looking at BTK inhibitors with obinutuzumab versus BTK inhibitors plus venetoclax plus obinutuzumab. And these do have a fixed duration of therapy for the venetoclax including arms in the younger person ECOG study. So that's really geared towards patients under the age of 70. And then in the older patient study, Alliance, US Intergroup Alliance-based study, they're going to be doing fixed duration therapy based on MRD, and that study is currently ongoing. So I encourage you to look out for those studies as well as the results of those studies as they mature. I think it's going to be a little bit before we hear as the younger patient study just finished accrual and the older patient study is still accruing.
Okay, I encourage people to type in the chat session any questions they may have even now. So I'll take the next one, and that is, I have not used ponatinib due to concerns regarding vascular toxicity, but also have not had a patient not respond to dasatinib and nilotinib. I think that's a good situation to be in. I think certainly if a patient is able to respond and tolerate a second generation TKI like nilotinib, ponatinib, nilotinib, and dasatinib or bosutinib, there is probably not much of a reason to go to ponatinib. So I think that it is only for those patients who have disease that is intolerant to the second generation TKIs or more so resistant to them that one would advocate trying ponatinib. And as we saw at the session, we now would suggest starting with 45 milligrams, going down to 10 milligram dose when the BCR-ABL transcript has fallen to less than 1%. So I think that we're getting better at managing the toxicities. So some of the initial concerns may be mitigated by the alternative dosing strategy. Go ahead, Nina.
I can take the next question. So the next question that we received regarding the lymphoma session was in fixed duration venetoclax regimens where one is hopeful in debulking patients prior to a venetoclax initiation. Are there real world recommendations when to come back to the office in the first cycle to evaluate for tumor lysis syndromes? And this participant had noted that as she or he wrote, I'm fairly paranoid as I was in training at Emory in the early 1990s when my colleagues cared for a CLL patient who's one of the first 3 in the country to die from TLS with fludarabine, and his experience ended up being published. And the patient collapsed as he was putting on his shoes to be discharged. So I can understand that was particularly traumatic. I think in the current, even in standard of care, when we give venetoclax alone or in combination with chemotherapy or other agents, we have been following the guidance of monitoring tumor lysis at each venetoclax ramp up. So We check blood before the patient takes Venetoclax. We check it that evening or 6 to 8 hours afterwards, after they take Venetoclax. And then again the next morning at 24 hours. And we have been sticking through that even in our standard practices. We're lucky to be at a place where our labs turn around fairly rapidly. And so we are able to look at those in real time. And if patients are at a lab where we don't expect results in real time, we've been trying to have their labs done at places where we can see them more readily and have them start their Venetoclax early in the morning so that there's ample time to follow up on the labs. But that is a practical consideration with Venetoclax, and I think the package insert still recommends checking the tumor lysis in that fashion. After you get through the ramp up, it becomes a lot easier, of course, with Venetoclax. I don't know what your experience is, Ravi, if you guys are all doing the same thing pretty much with Venetoclax monitoring for myeloma.
Yeah, well, we do more Venetoclax, obviously, in the context of AML in my practice, and there we certainly do have a very short ramp up, and we do have to make those adjustments based on interactions with azoles. We don't, obviously, in the few myeloma patients that we use Venetoclax off-label to any ramp up at all because hemolysis in myeloma is pretty rare.
I have some other questions on my end as well. Do you want me to keep going?
Yeah, please go ahead. I'll take the one after you.
Yeah. So one of the questions that came up are, what are your thoughts on the rates of grade 3 or 4 atrial fibrillation in the setting of Elevate RR, which were very similar between acalabrutinib and ibrutinib. So Elevate RR, again, was a study of ibrutinib versus acalabrutinib in relapsed refractory CLL, which showed generally a favorable toxicity profile of acalabrutinib. So I would keep in mind that grade 3 atrial fibrillation means that patients needed urgent medical attention, meaning they were hospitalized for atrial fibrillation with RVR, or they required cardioversion. And so most of our patients who develop AFib are patients who then go on to be on medical management long-term and are managed as an outpatient. So grade 3 atrial fibrillation in general is relatively uncommon, I would say, even in general medical practices. So to me, the difference is in the fact that they had similar rates of grade 3-4 atrial fibrillation and flutter is probably less clinically relevant than the fact that there was less atrial fibrillation and flutter at a grade 2 or grade 1 level in the acalabrutinib arm for my decision making, at least.
One question I see in the chat here, which I'm not totally clear about, is did it appear that myeloablative transplant led to greater increase in proportion with complete remission relative to non-myeloablative consolidation? That is, did the ASCT help deepen the response? So again, if the person writing this question could just pose a clarification as to what disease and what study is being referred to here, because at least in my presentation, I did not talk about any transplant. I would be glad to address questions on that issue. The one transplant study that did garner some attention in the area of myeloma was the Cassiopeia study, wherein patients were randomized post-transplant to no maintenance versus daratumumab, and it was found that daratumumab led to improvement in PFS only in patients who did not get daratumumab as part of initial therapy. And that does bring up the question on whether adequate consolidation and depth of therapy with induction and transplant obviates the need for possible maintenance therapy. So I think that if that was not the subject of the question, I'd be glad to address it later. But Nina, go ahead.
Yeah, I think they were referring to the CNS lymphoma study.
So I'm sorry.
No worries. So I think they were referring to CALGB 51101, which was a study of methotrexate rituximab temodar for CNS lymphoma, where patients then after completion of induction therapy were randomized to either etoposide Ara-C-based consolidation, which was non-myeloablative, versus an auto transplant, which was Thiotepa based. And yes, so I think to me, when I look at this data, is that if you take all the patients who are in complete remission at their end of induction therapy, the outcomes look fairly similar for those who have myeloablative versus non-myeloablative consolidation. And so I don't know that it necessarily increased the rate of durable remissions in those patients. However, when you look at how the study was designed and the primary endpoint of the study, the auto transplant arm had better long-term disease control than the non-myeloablative transplant arm, although we attribute most of that to some unexpected differences in the rate of sensitivity to induction therapy. And so I have to say, at WashU, we still haven't, we haven't, and we were a large proportion of the participants in the study had come from WashU, and we haven't currently changed our practices and are continuing to discuss, when to consider one approach versus the other. Even in the patients who had non-myeloablative consolidation, about 50% had neutropenic fever and had to be admitted. And so to me, the toxicity profile was not that different between the two, was not as noticeably different between the two arms. Though neither, and I would say neither approach is particularly easy on the patient, but fortunately patients recover from their toxicities. But that's an excellent question.
Okay, one question I have, I guess, that I can address is, could you weigh in allowing younger patients trying to end continual treatment in CML? So this is the issue of a limited duration treatment-free, um, you know, uh, approach. This is something that obviously has been the subject of numerous trials now, and both with nilotinib, where it is on label, dasatinib, and even with imatinib. And certainly for patients who achieve a deep molecular response of 4.5 log reduction or below, after 1 to 2 years at that level of response, discontinuing treatment at about 2 to 3 years of follow-up, 50% of patients don't require treatment. So that does suggest that it is a safe strategy. I think for younger patients, especially those planning to have a family, that strategy is very relevant. For the vast majority, I don't think it has yet become mainstream to plan to give limited duration treatment. I think that the needle may move in the years to come, but for the average patient, we do tend to give treatment as long as patients are tolerating it and are benefiting from it. So that's for you, Nina, I guess. I mean, Neha, do you, patients who are hospitalized for venetoclax initiation, do you do that?
Yeah, so we do that in select patients. I think that's a good, very practical question. So for patients who have high disease burden who require venetoclax, regardless of which type of disease we're talking about, but patients who have bulky disease or patients who have a very high absolute lymphocyte count attributed to their CLL or mantle cell lymphoma, or patients who have some underlying renal insufficiency, or for patients who we know will have difficulty with the hydration that's really required for venetoclax-based management, we consider hospitalization. I would say most patients are able to go by without being hospitalized, especially in the era of adding venetoclax to other agents after they've been debulked some. Oftentimes in those situations, we're checking a CAT scan after their debulking type of therapy, whether that be ibrutinib or CD20-based therapy, and then seeing if they still meet criteria for admission for venetoclax monitoring. But we certainly have patients who are older or more, relatively more frail and can't really hydrate and have some underlying renal insufficiency and would be at higher risk. And in those patients, we consider hospitalization for their venetoclax monitoring.
I think the next one's for you as well. Yeah, FCR for CLL, where do you see it?
Yeah, so that's a great question. So I haven't given anybody FCR in the last year or year and a half, I would have to say, for CLL. I think the people that we've talked to about it are particularly young people, young being under the age of 50, so also an uncommon CLL population, who really want a fixed duration of therapy regardless of toxicity. So, you know, with FCR, for patients who have CLL that is has IGVH mutated disease, there are patients who receive FCR who never go on to receive other therapy. And if you're in your 40s with CLL and you go through difficult time for 6 months, but then never have to go through CLL therapy again, I think some people consider that as well. I think in the era where there's more and more options, or will be more options for fixed duration therapy using novel therapeutic combination approaches, as we alluded to with BTK inhibitors and BCL2 inhibitors and obinutuzumab, that era will continue to die. You know, we know patients with FCR can develop secondary cancers as a result of FCR therapy. We know that it does come with a high risk of grade 3 and 4 hematologic toxicities. There's a high rate of neutropenic fever. Again, I think for all those reasons, I've not been in a position of prescribing FCR for an upfront CLL patient in a very long time. And that will probably become even more rare.
I think we got a few more minutes, and the next question's for you as well. So go at it, Neha.
Yeah, so the next question is in classical Hodgkin's lymphoma that's early stage and bulky. If you've gotten 2 cycles of ABVD and then you have a negative interim PET scan, do you then give AVD per RATHL? Or do you consider giving 4 cycles of ABVD based on the CALGB 50801 trial that we talked about? So I personally now drop the bleomycin after 2 cycles. I think there's good evidence that if patients are chemo responsive, that dropping bleomycin is very safe. Based on RATHL. You know, patients who had stage 2 bulky disease were included in RATHL, and most patients with bulky disease have stage 2 disease. So I think that is that is a similar patient population that was used in CALGB 50801. And most of us now believe that that dropping bleomycin does not have outcomes in long-term effects in terms of efficacy, and certainly improves the toxicity profile and long-term toxicity in patients who have Hodgkin lymphoma. So in my practice, I do now drop the bleomycin pretty much for most patients after 2 cycles if they have a negative interim PET.
So again, I think this may be the last question, but it's for you as well. So why don't you go ahead?
Yeah, so the next question was, in high-risk CLL with the 17p deletion, which of the following regimens do I prefer? Obinutuzumab with venetoclax or obinutuzumab with acalabrutinib? And so, you know, right now, I tend that's a great question. So in young fit patients, we consider giving BTK inhibitors alone. And so if looking at the studies of CD20 antibodies, whether obinutuzumab or rituximab in combination with BTK inhibitors versus BTK inhibitors versus chemotherapy, of which there's been a number of studies with that paradigm, the addition of CD20 antibodies does not seem to improve outcomes in the patients who have had BTK inhibitor with BTK inhibitors. So, for example, the studies of ibrutinib plus rituximab versus ibrutinib alone showed not really a significant difference in outcomes. And so the discussion I usually have with my patients is, do you want to be on indefinite therapy, or do you want fixed duration therapy? And so we're talking about then acalabrutinib or ibrutinib versus obinutuzumab venetoclax. And obinutuzumab venetoclax is certainly my preferred regimen for older patients. And that study was specifically done in patients who were older and more frail. And so we either consider that or we consider single agent acalabrutinib. And it really comes down to how long patients are willing to be on treatment for.
Okay, thank you so much for your time. And we now have a quick break. Make sure you have selected the non-CME presentation you would like to watch by going on to the All Session tab and adding it to your schedule. Both really great learning opportunities, and you will receive a gift card for attending. Enjoy the quick break. Thank you very much.
Thanks, everybody.
Thank you.